Good evening, good morning, good afternoon to everybody. So, wherever you are, this is another edition of our Sunday critical care webinars in intensive care. And today there is a case discussion. The case is pertaining to acute kidney injury, and will be presented by Dr. Akshat, who is a fellow, first year fellow in critical care. And joining him will be Dr. Vishal. He's a neurocritical care fellow, and both of them are working at CHL Hospital Indore. And it will be moderated by Dr. Nikhilesh Jain sir. Sir is the director and operational head of critical care services at CHL Hospital Indore, which is the largest hospital in Madhya Pradesh. And we thank him for making this presentation possible. And you are well familiar with our formats in the case discussion. So similar format will be followed and will be uploaded on our YouTube channel thereafter. So over to you, Dr. Akshat.
Yes, sir. So, good evening, everyone.
You have to go
I'll start.
Dr. Akshat, full screen.
Yes, sir.
Okay.
So, I'll start with the case. A 32-year-old male patient, a lineman by profession, presented with electrocution injury of 2 hours duration and was referred to our hospital for further management. On further examination, he was in altered sensorium, was in lot of muscle pain, and passed an extremely dark colored urine at baseline. He was irritable and remained tender to touch with disorientation and borderline airway protection.
Next slide.
On the workup, there was an elevated TLC count, 18,000, increased serum creatinine level, 4.5 milligram per deciliter. ABG was consistent with high anion gap metabolic acidosis. He had hypoalbuminemia with mild increase in LLT and AST. Total CPK levels were 12,000. Urine routine dipstick was positive for him with no absence of RBC.
So just go back now to the first slide.
This one, sir?
Yeah, so after how much time of electrocution he presented to the ICU?
Pardon, sir?
Can you hear me?
Yes, sir.
So after how much time of electrocution he presented to your ICU?
So after 2 hours of electrocution, he presented to our hospital after 6 hours of duration, sir.
So the creatinine is 4.5 in 6 hours.
On presentation, yes, sir.
That is slightly unusual unless he has CKD. Okay, because creatinine cannot jump to 4.5 in such a short time. It will be highly unusual. Anyway, we shall see that. And what about disorientation? So, Dr. Vishal, why do you think he was disoriented?
The probable reason for the disorientation, probably, sir, there should be a hypoglycemia. Patient must have a there is a low oxygenation level. Probably he must have fall after electrocutions, sustained some sort of head injury.
So, you are saying either he could have had a hypoglycemia, or he could have a head injury, or he could be hypoxemic, right?
Correct. And there should be some chances of electrolyte disturbance, which is leading to the electrocutions. Patient may have hyponatremia, sometime hypernatremia.
He has come after 6 hours. You think he can have so much derangement in this electrolytes within 6 hours?
Not so, sir. Probably the hypoglycemia must be the reason. Hypovolemia must be the reason. Sudden shift of volume.
So, Dr. Akshat, I would like to know the details. What was the blood pressure? What was the sugar level? What did he have a head injury? What was the oxygen level?
These were all fine, sir, at that point in time.
Huh?
He maintained stable hemodynamics. His oxygenation was intact with supplemental oxygen of around 2 liters. And he was irritable, in my opinion, because rhabdomyolysis could have been per se leading to it.
No,
Because the subsequent slide does show that he had rhabdomyolysis.
one sec. Dr. Vishal and Dr. Akshat, your videos are switched off. Please switch on your videos.
So the host has disabled the video actually.
No, I have not disabled anything. 1 minute. Okay. 1 minute. You can start the video now. Akshat, also please start the video.
Yes, sir.
Yeah.
Now everyone's visible.
Dr. Vishal, you can start the video. So, Dr. Niklesh, was he maintaining saturation on room air, or was there any evidence of head injury?
There was no evidence of head injury as such, overtly.
And sugar was normal, blood pressure was normal.
Yeah, sugars were normal.
So he was requiring, borderline airway protection. So was there compromise in the airway?
He was, I won't call it a fully compromised airway. He had cough, but still he was slightly altered. And we initially just put him on supplemental oxygen to assess whether he would hold his airway or not at that point in time. He was not gasping. There were no other major problems in that, but still slightly altered, drooling from the angles of mouth. That's what we were thinking about. There was an underlying possibility that he may have had convulsions, but because there were no overt convulsions in our presence, we cannot nail it definitively.
So was he following commands?
Not really.
So GCS was more than 8 or less than 8?
Jesus was more than 8.
Okay. So, Dr. Vishal, whatever you have said is not holding true here. Why do you think he had, what is the most likely cause of disorientation? He's had electrocution.
So the borderline airway protection, probably there must be some event of hypoxemia, sir. The irritability because of hypoxemia, I guess.
He's maintaining saturation on 2 liters, unlikely.
But rhabdomyolysis may cause irritability.
How
Acute
does it
insult.
cause irritability?
Sir, acute insult. Any acute insult may cause a.
Rhabdomyolysis per se will not cause. You are a neurocritical care fellow. So this is important. So you see what happens. What is the connection between the current passage in the body and the brain? Is there any connection?
Spinal cord.
So from the spinal cord, it can go to the brain. Are you aware that the current can go to the brain and cause cerebral dysfunction?
Yes, sir.
That is the most likely cause.
Corticomedullary.
Not whatever, it goes to the brain and it can cause neuronal dysfunction. The current can go to the brain. Okay. So that is the most likely cause. And the other thing is he has become, if the creatinine is 4.5, he has become uremic. There might be uremic encephalopathy, but 6 hours is a very short time for all this to develop. And I'm not sure whether the creatinine is really 4.5 in your ICU or from outside reports. So that has to be seen. Then the other thing is he has passed dark colored urine. So Dr. Akshat, why has he passed dark colored urine?
Sir, probably because of the myoglobin pigment present in the urine.
So what are the other causes of dark colored urine?
Can be, sir, hemolysis. Hemolysis can present with dark colored urine.
Why?
Because of the loss of the heme pigment in the urine, sir.
Because of hemoglobin urea.
Yes, sir.
And what else?
The dehydration is the most common cause.
Okay.
Probably.
What else? Hematuria. Hematuria also causes dark colored urine at times. And certain drugs can cause. All right.
Yes, sir.
And sometimes.
Cyclosporine can cause.
Sorry?
Cyclosporine can cause, sir.
Yes, some drugs can cause. So drugs in general. Okay. So did you intubate the patient?
No, we did not, sir.
No, sir.
At this point, no.
Okay. Now, can electrocution lead to sudden cardiac arrest? Dr. Akshat,
Yes, sir. Can lead to sudden cardiac arrest.
what is the mechanism?
Cardiac arrhythmias.
Okay, fair enough. Anything else?
Hyperkalemia, sir. The main
Hyperkalemia.
cause.
Yes, hyperkalemia occurs later on. Okay, initially when the patient is in the, the event is occurring, electrocution. One is cardiac arrest. What else? Can you have
High
respiratory arrest?
Absolutely.
So, Dr.
You can
Akshat,
have.
one is cardiac
Yes, sir.
arrest to arrhythmias, absolutely. And he can also have respiratory arrest. So, what is the mechanism for respiratory arrest in these patients?
compromised airway, sir. Edema to the tracheobronchial tree.
Sudden cardiac respiratory arrest. That is a gradual process. What else? You have to think beyond airway. Everything is not in the airway.
Muscle necrosis increases the creatine kinase level. Some inflammatory markers.
Yeah, sudden arrest, respiratory arrest occurs if there are two mechanisms described. One is the current goes to the pontomedullary junction and the respiratory center gets paralyzed. Okay, because the respiratory drive comes from the brainstem and that gets hindered by the passage of current. So, there is a respiratory arrest. The other mechanism is there are sudden tetanic contraction of the respiratory muscles and they go into respiratory arrest. So, this is independent. The heart may be beating, but he can go into respiratory arrest. So, sudden cardiac arrest can occur at the electrocution site. Now, Dr. Akshat, you mentioned about cardiac arrhythmias. So, what kind of relationship is there between electrocution and arrhythmias? If there are no arrhythmias initially, then is it necessary to monitor them in the sense will they develop arrhythmias? Can they develop later on?
Yes, sir. They can develop arrhythmias later on also, sir.
Okay, so for how long should we monitor them with a cardiac monitor for arrhythmias? In other words, what is the safe time that the patient can be said to be out of danger as far as arrhythmias are concerned?
Sir, from 2 to 7 days.
No. 24 hours is enough. If it does not develop within 24 hours, you can say you will not get arrhythmias. All right. Then what about CPR in these patients? Anything you want to comment? Is there anything specific about CPR in these patients if they get cardiac arrest?
Sir, ventricular arrhythmias are more common in electrocutions
Absolutely.
because of
Absolutely correct. But what? So you follow the usual ACLS guidelines.
usual ACLS protocol we
Yeah,
follow.
but what is special about the protocol or the nature of the CPR that you do?
If it is with hyperkalemia, you may need to prolong it.
That is one thing. What else? So the answer is that you do prolonged CPR in these patients because they respond to prolonged CPR at times. And if they are fixed dilated pupils, that is not taken as a sign of irreversibility. Because what happens is when the current passes through the body, it excites the autonomic nerves. The autonomic nerves lead to dilatation and fixation of the pupils. So that is one thing. They are responsive to prolonged CPR and dilated pupils should not be taken as a marker of irreversibility. Okay. Now coming to the other thing, Dr. Akshat, what other kind of one is the injury related to the electrocution, arrhythmias, burns, and the passage through the body. What else can happen to these patients? What other injuries can they get?
Liver damage, sir.
Liver damage is all right. What else should you specifically look for? When if the patient, you are in the ICU, patient has come electrocution, and so you have looked for arrhythmias, you look for airway and all these things. What else should you look for specifically?
Bony and soft tissue
Sir,
injuries would take
head to toe examination. Any injury mark, as I said before, patient must have fall, so there should be some cut, injury, any other body mark actually. Any
Body
bleeding
mark,
from the sides,
what else?
any bleeding from the orifice. if he falls from the height. Some pelvic fractures if he falls from the height.
Okay, so you are getting close to it. He can fall from the height, and apart from that, when the current is delivered, they are thrown back, so they can develop fractures, even if he's not at a height. Supposing he's just on the ground, they are suddenly violently thrown back because of the passage of current, and they can develop skeletal fractures. So, you have to do a ATLS kind of a survey in these patients, not to miss any fractures. Okay. Now, moving on, you move on to the next slide, Akshat. Akshat, so why does he have leukocytosis? Has he developed infection? Dr. Akshat?
Sir, it's an inflammatory process, sir. Body has responded with increased TLC count.
Okay. Now, is there any past history of illness or CKD in terms of seeing such a elevated creatinine in 6 hours of 4.5?
No, he
What is
did
the
not
past
have it,
history?
sir, because he was coming from outside. So the only thing that we thought of was maybe there was a difference in timelines, one, or the other thing was that because he did not have an overt conversion in front of us, but he may have had a conversion outside, which was maybe unwitnessed or which was not given credence at that point in time.
No, but I'm trying to interpret the 4.5 creatinine. 6 hours is a very short time for a creatinine of 4.5. Are you sure that
True.
it was 6 hours or was it more? Or does he have a background illness of CKD?
No, there was no background CKD. There was
No
no
background.
background CKD.
And are you sure about the duration of 6 hours?
This is what was the history, what was given.
Yeah,
So,
so I don't think this is consistent. Yeah, I think he has had it for some more time because 4.5 creatinine from baseline in 6 hours is unrealistic, as you would agree. And then moving on, Dr. Akshat, why does he have high NAN gap metabolic acidosis?
Because of acidosis, sir.
No, acidosis is there. Why should he have acidosis?
Because of electrocution, there might be elevated lactate levels, sir.
Does electrocution lead to elevated lactate levels?
Renal failure, sir. The raised creatinine level
Yes,
will
renal
cause.
failure is leading to metabolic acidosis. So do you get high NAN gap in renal failure?
Sir, in some underlying disease like ketoacidosis, lactic acidosis, in
No,
some.
we are talking now about renal failure. Is there metabolic acidosis in renal failure, acute renal failure, high NAN gap or normal NAN gap?
See, usually we get a normal anion gap. We get actually lactic acidosis in this patient.
No, what was the lactate level in him?
What are the lactate?
Dr. Akshat, what was the lactate level?
Sir, at the presentation, it was 4, sir.
So blood pressure was normal.
yes, hemodynamics were fine.
So Dr. Nicholas, maybe you can throw some light. Why was the lactate elevated?
So there were multiple things going on at that point in time. Like I said, that one differential that we thought of was that maybe he's had some conversions, but usually with conversions, the thought of lactate that we find is much more higher and the pH levels go down slightly in terms of bicarbonate coming down. So that was slightly unclear. Now, this man did not get referred to us primarily. He was initially referred to a other healthcare center and then he had landed up with us. So, and we don't have papers because this is a medical legal case. So, few things may have gone in between which we were unable to explain at that point in time.
So what was the blood pressure, Dr. Nicholas, and what was the heart rate?
He used tachycardic, ranging from 100 to 120, and blood pressures were in the range of 100, 110 systolic.
100 systolic. So
100, 110 systolic.
so that indicates hypovolemia, right? He's hypovolemic. So he's had electrocution and his CPK is high. So obviously he's having rhabdomyolysis. And Dr.
True.
Akshat, are these patients hypovolemic? Is the intravascular volume depleted in these patients? And he's not had anything for the last, because the history is inconsistent. And looking at the creatinine, so he has obviously had the electrocution at least 12 hours or 24 hours maybe before this, and he's not had anything orally probably. So he's dehydrated, hypovolemic, so that is leading to lactic acidosis. And if he's had a convulsion, that will elevate the lactate. And electrocution per se does not lead to lactic acidosis. Right. So the cause for lactate is probably he's hypoperfusing and maybe he's had a seizure. And that's my take on this. And why he has high anion gap is generally a lactate of 4 does not lead to alteration in anion gap. What is more likely is the renal failure. Early renal failure leads to normal anion gap. But once the GFR falls below 30, it leads to high anion gap. So the likely cause for high anion gap metabolic acidosis is your acute renal failure or acute kidney injury as is called, and the elevation of lactate is due to hyperperfusion in all likelihood. And that is my take, because blood pressure is 100 systolic, he's tachycardic, and when there is rhabdomyolysis, the injured muscle takes in a lot of water from the intravascular compartment. It soaks in a lot of water. So the patient, and he's probably not been given IV fluids. That's my take. And moving on to the CPK now and hypoalbuminemia. So what was the albumin level?
The albumin levels were somewhere in the range of 2.8.
So why should albumin go down?
Difficult. He did not have any positive finding on liver, and he was not malnutritioned as well. That's what we gathered from the history. But this was how it was.
So I'm not sure whether he is not having any chronic disease, because these patients from lower socioeconomic status, no one gives a proper history. Why should the albumin be low in such a patient of electrocution with a 12-hour history? And creatinine has gone up to 4.5. Whether he was alcoholic, was he alcoholic? Did we get a history?
He was alcoholic, but at that point
Yes.
in time, we did not find any corroboratory history of recent alcohol intake. That is just before the event or anything of that.
So he was alcoholic in the sense he was taking enough alcohol, or were we able to get a history?
We were able to get a history of alcohol intake, but not at this point in time. So probably he used to take alcohol, but when he got an electrocution injury, his sensorium and everything was intact, and he was not under the influence. That's what we gathered.
And what was his age?
His age was 37, sir.
Okay. So if there was regular alcohol intake, he might be suffering from CLD also, and ALT/AST is increased, right? So he might be having
Yes.
chronic liver disease. We don't know.
We do not know at this point in time. So no, anyway, that would come later. Ultrasound.
Okay, so CPK levels were 12,000. Dr.
Yes.
Arshad, what kind of cutoff is taken for significant CPK elevation?
Sir, more than 5 times the normal range.
Okay. So that's right. So generally, if the CPK is less than 5,000, you consider muscle injury is not very significant. Anything more than that becomes significant. Now, urine dipstick was positive for heme, and no absence of RBCs means what? There were RBCs or there were no RBCs?
There was no RBC, sir.
There were no RBCs. So what is the interpretation of the urine examination here?
It contain myoglobin contain the heme, actually hemoglobin part. The RBCs indicate the hematuria.
So can you diagnose myoglobinuria or hemoglobinuria on hematuria on the basis of urine examination?
Yes, sir.
Yes, sir.
Dipstick test we can do.
Okay, so you do a urine examination, look for RBCs, and you can do a dipstick for him. Very good. Fair enough. And otherwise, other than that, you also have tests looking at plasma myoglobin, plasma hemoglobin, urine myoglobin, urine hemoglobin. But they are not easily available. But this is generally sufficient to make a diagnosis of hemoglobin or myoglobin in the urine. Fair enough. Okay, so now we conclude that the patient is having rhabdomyolysis and there is some degree of hypovolemia and he's having metabolic acidosis. So next slide now, Dr. Akshat.
So further workup revealed hyperkalemia 6.5 milliequivalents per liter, hyperphosphatemia 4.6 milligram per deciliter, and hypocalcemia of 7.1 milligram per deciliter. with hyperuricemia, 10 mg per deciliter. Aggressive fluid resuscitation was done, and the patient remained oligouric with rising serum creatinine levels, which was 1.8 milligram per deciliter on day 1 and 2.5 milligram per deciliter on day 2.
Now, this is being done in our lab, sir.
So 4.5 was outside report, right?
Correct. Correct.
So that is what, there is a problem here. The report is incorrect. This is your initial report of 1.8 creatinine. Am I right?
Yes, sir.
So that he has come from a very small place with the creatinine level has not been done properly. The reports are not reliable. So that is what I was trying to say, that you cannot have 4.5 creatinine in 6 to 12 hours at all. So creatinine is 1.8 and there's a uric acid of 10 and there's a potassium of 6.5. So what is the cause of hyperkalemia in these patients, Dr. Akshat? And hyperphosphatemia and hypocalcemia? Explain the electrolytes.
So it's because of the renal failure, sir.
Sir, any muscle injury will cause hyperkalemia with the release of phosphate in the circulation, and the hypokalemia because of deposit of calcium in the kidneys.
So you are right that hyperkalemia and hyperphosphatemia is because of renal failure and because of release of potassium and phosphate from cell lysis. And hypocalcemia occurs because calcium gets deposited in the injured muscles. Absolutely. And it is not in the kidney that the calcium gets deposited. It gets deposited in the muscles.
In the muscle, sorry. In the muscle.
Injured muscles take up the calcium. And why the uric acid high?
Because of
the cellular lysis, sir.
Because of cell lysis.
proline.
Okay, what else?
Proline synthesis.
Does uric acid increase in AKI?
No, sir.
Yes, sir.
Uric acid increases in AKI. All right. So again, cell lysis causes uric acid increase. As you know, tumor lysis syndrome, right? Tumor lysis syndrome is a major cause of hyperuricemia. And uric acid rises in all cases of renal failure because it gets excreted through the kidneys. Now, what will you do for the potassium? 6.5, would you like to treat it?
Yes, sir.
What treatment would you like to give to this patient for the potassium?
Sir, first we will rehydrate the patient. We'll give the volume, followed by the pentatherapy. We'll give.
You will give volume. So the patient was given fluids, but you would not like to give something for the potassium. It is 6.5, or you will wait till you give some fluids.
Sir, we'll give some fluid, sir, and we'll give some anticalamic measure because 6.5 is very high, pretty high.
You have to give anticaloric. He can have a cardiac arrest, because.
Yes, sir.
So what is the treatment for the potassium here? What treatment will you give? Dr.
Glucose insulin drip, sir.
Okay.
Sir, calcium will give for membrane stabilization.
So both of you don't speak. I'll take the name, that person only speaks. So Dr. Akshat, he has mentioned glucose insulin drip. How do you give the glucose insulin drip?
Sir, we'll give 25% of dextrose with 12 units of insulin.
Mm-hmm. And any precautions to be taken with that?
We need to do baseline sugars as well before giving it.
So you have to monitor the sugar also because the patient can be thrown into hypoglycemia. Already is not taking anything. So when you give the glucose insulin drip, make sure the patient does not develop hypoglycemia. Okay, so one is your dextrose insulin drip. What else can you do for hyperkalemia?
So we'll give calcium 10%, 10 cc in 100 ml of NS over 20 minutes. If it's life-threatening hyperkalemia, we can give in a span of 3 minutes also, sir. So for membrane stabilization.
What else can you do for hyperkalemia?
I would just add one point in this. If you're going to give calcium gluconate to actually make a difference in terms of elemental calcium going in, you need to give 3 ampules of calcium gluconate. And a similar effect can be seen by 1 ampule of calcium chloride. That is how it can be managed. There is a commercial preparation of calcium chloride which comes by Neon, if I'm correct, but it is not very easily available.
Yeah, so the point is, what he is trying to say is 1 ampule of calcium chloride is equal to 3 of calcium gluconate. So that is the conversion from calcium gluconate to calcium chloride. So Dr. Akshat, you have given calcium, you have given dextroinsulin. What else can you do to decrease the potassium?
So nebulization we can give.
Okay,
So
nebulization. What?
with esthalin, sir.
Okay, what else?
Diuretic can also be given, sir. That can also lead to hypokalemia, sir.
Okay, very good. What else?
Would you like to give soda bicarb?
Not read upon that, sir.
Dr.
Yeah, it
Akshat?
can be given, sir. It causes a hypokalemia.
Yeah, he's having
We can
acidosis also, right? So soda bicarb has to be given here. What else? What one thing very important you are all missing? What else? Last thing you can do for potassium.
sir binders.
Very good. So what do you give? Normally, what is available?
Calcium polystyrene. Sir, K bind sachet there is available.
Yeah, calcium polystyrene, right? So the brand name may be whatever. You know the dose?
Yeah, it is given 15 gram 8 hourly.
Yeah, so stat dose can be even 45 grams, and you dissolve it in water and give it to the Ryan's tube, unless the patient can take orally. So that is the strongest actually, but it effect comes after 1 hour at least. So these are the measures for potassium. Now phosphate, hyperphosphatemia. Anything to be done for this, Dr. Akshat?
No, sir.
Would you like to treat the phosphate and calcium? Dr. Vishal?
Phosphate binders can be given,
Sir,
sir.
we can use.
So what do you want to treat? Phosphate or calcium or both?
Phosphate, sir.
What do you want to give?
Forget the name.
Sir, calcium binder, sir.
Calcium binder for phosphate.
Yeah, for the phosphate.
Is it called calcium binder or something else?
Uh,
So they are called phosphate binders, huh? Not calcium
yeah,
binders.
Phosphate chelating agents.
phosphate
Yes, sir.
binders.
So what is the name?
Name, sir?
Name of the phosphate binders. What are the
Calcium based phosphate binders.
Okay, so one is calcium acetate, right?
Calcium
Calcium
acetate.
but what is more commonly used is Sevalmer.
Cevalodin.
Sevalmer.
Cevalodin. But cevalodin will not increase the calcium levels, sir.
Yeah, but do you need to increase the calcium is the question. Do you need to increase the calcium? If there's hypocalcemia in the ICU, do you correct it? At what level do you correct hypocalcemia?
Sir, low levels are always corrected because it causes a high cardiac arrest.
The symptomatic calcium should symptomatic hypocalcemia should be corrected.
That is correct. Only symptomatic hypocalcemia should be corrected, and cardiac arrest
Plus
does
he
not.
had an albumin of 2.8. So I believe the
Yes,
corrected
corrected
calcium
calcium
levels
is
may be slightly higher.
So, what is the normal level of phosphate generally?
so 2 to 4 we consider.
So it's 2 to around 4, 4.5, depending on the lab. So this is a very mild hyperphosphatemia, and calcium levels are normally around 8.2 is the cutoff. So there is hypocalcemia, mild hypocalcemia, and the phosphate is just elevated. And you correct hyperphosphatemia if the calcium phosphate product is more than 70, because it can lead to precipitation of the calcium phosphate product, and it can even deposit it in the conduction system in the heart. So thereby you do not want the phosphate to rise. Hyperphosphatemia per se is not injurious, but it leads to secondary hypocalcemia. And hypocalcemia is not corrected in the ICU unless it is symptomatic, right? And symptoms come in the form of, what are the symptoms, Dr. Akshat, of hypocalcemia?
So tinnitus we get.
Sorry?
So tinnitus we get.
I can't understand. What are you saying?
Sir, hypocalcemia induced tetany we can have.
Yes.
Hello?
So you get neuromuscular symptoms. because of hypocalcemia. It decreases the vascular tone also. Blood pressure can decrease. And if there is too much hypocalcemia, it can lead to cardiac standstill also, arrhythmias. And it leads to convulsions also. So these are some of the manifestations of hypocalcemia. But unless it is symptomatic, you don't treat it. And you can check for it by Schwarzschild sign, by Trosch's sign. So all these things can be done to see if there is latent symptomatology. Okay, so that is about potassium, phosphate, calcium, uric acid. What drug can you use to decrease uric acid if required? Is there any drug?
Allopurinol, sir.
Allopurinol. Okay. Akshat, adjust the phone. We cannot see you. Yeah, now we can see you. Okay. So allopurinol can be used. Any other drug?
Febuxostat we can use.
Very good. Okay.
Correct.
So they can be used in reduced doses, but a level of 10 does not require treatment. Normally in AKI, uric acid does not require treatment unless it is tumor lysis syndrome. All right. Now aggressive fluid resuscitation was done and the creatinine is going up. So Akshat, this patient has come to you, you are in the ICU. How will you decide about fluid resuscitation? Does this patient require fluids?
Sir,
Decision whether you have to give maintenance fluids, whether you have to give no fluids because his creatinine is high, or whether you should be giving a lot of fluids. What is your decision and how will you decide?
various clinical parameters I'll see, sir. Most probably this patient is if patient is hypovolemic, I'll see clinically by capillary refill time hypotension is there or not. I'll do a bedside echo to check the intravascular status. Then we'll decide. Apart from that, we can give a diuretic challenge also, sir, to check whether the patient is fluid responsive or not.
Diuretic challenge. You would like to give him diuretics? What will you first do? Now you are the patient has come, you have seen him, you have to decide. What is the first thing you will do? Give the fluids or would like to assess something?
So would like to give fluids, sir.
How much will you like to give?
Sir, 500 ml I'll like to give, sir. 500 ml of Ringer's lactate I want to give.
It would be
Ringer's
basically
lactate.
either 500, I won't say 500. We're talking about either Ringer lactate or normal saline, and we are talking about a rate of up to 400 mLs per hour. That is the type of thing that we are looking at when we are trying to resuscitate a patient of rhabdomyolysis. And the goal is basically to have a urine output. If we can have a urine output of say maybe 1 mils per kg per hour, maybe something to up to 3 mils per kg per hour, or say up to 300 cc per hour. That's what we target actually. So fluid resuscitation will not go in isolation. We also need to have urine output targets simultaneously.
So, Akshat, these patients with rhabdomyolysis, are they volume replete or volume depleted? Dr. Vishal?
Sir, volume depleted.
Yes, so the injured muscle takes in a lot of water from the intravascular compartment, and the intravascular compartment gets depleted, and he's probably not been given IV fluids also. So initially, these patients have to be given a lot of fluids. So you see, when the patient comes to you, you have to make a clinical judgment also. Looking at the history, what kind of disease he has. So this patient has rhabdomyolysis and his blood pressure is on the lower side, right? A 37-year-old man coming to you with a blood pressure of 100 by 70 plus, tachycardia without any evidence of sepsis is likely to be hypovolemic. And you have to give him fluids. And one has to know, some basic treatment. Rhabdomyolysis requires large volume of fluids initially, something like 1 liter per hour has to be given. And then you have to put in the Foley's and you have to look at the urine output, right? So that is how you are going to assess him. So initially you have to push in some fluids in this patient because he has rhabdomyolysis and there is evidence of hypoperfusion. The lactate is also increased if you remember. All right. So I think with that, we shall move on now.
Is it AKI? So how to delineate? Is it harmful or any points to remember? So what are the diagnostic classification we have? So the classification in the staging system for acute kidney injury is either rifle criteria, Ekin criteria, or Kidigo criteria. So what is rifle criteria? Rifle criteria is risk, injury, failure, loss, and end-stage renal disease classification. So consists of three classes: class R, class I, and class F. Both are divided into either creatine-based classification or urine output-based classification. Class R consists of serum creatinine increases to 1.5 times of GFR, or GFR decreases to more than 25% from the baseline, is class R. Less than 0.5 mils per kg per hour for 6 hours of urine output. Class I is serum creatinine increases to twofold, or GFR decreases to more than 50% from the baseline, and urine output less than 0.5 ml per kg per hour for more than 12 hours. Class F is serum creatinine increases to threefold, GFR decreases to more than 75% from the baseline, or serum creatinine more than 354 micromillimolars per liter, that is more than 4 mg per deciliter, with an acute increase of at least 44 micromoles per liter, that is 0.5 mg per deciliter, and urine output less than 0.3 ml per kg per hour for 24 hours, or patient is unuric for 12 hours. Then Akin criteria, that is acute kidney injury classification, stage 1, stage 2, stage 3. Stage 1 is serum creatinine increases more than 26.4 millimoles, that is more than 0.3 mg per deciliter, or increases to 1.5 to 2 times from the baseline. Urine output less than 0.5 ml per kg per hour for 6 hours. Stage 2 is serum creatinine increases to more than 2 times to 3 times from the baseline, and urine output decreases less than 0.5 ml per kg per hour for 12 hours. And stage 3 is increase in the serum creatinine more than 3 times from the baseline, or serum creatinine more than 354 micromoles per liter, that is more than 4 mg per deciliter, with an acute increase of at least 44 micromoles per liter, that is 0.5 mg per deciliter, or patient is in need for renal replacement therapy, that is less than and urine output less than 0.3 ml per kg per hour for 24 hours, or patient is unuric for 12 hours.
Next slide.
So what is the significance of oliguria or anuria? So oliguria precedes rise in serum creatinine. Anuria can be taken as urine output less than 50 ml per day, and active search for reversible causes should be initiated once detected in a patient. Non-oliguric AKI has a better prognosis, and there is only one publication disfavoring the same. Recognition of the non-oliguric patients may require early dialysis. Longer the oliguric, more the mortality and more the severity of the injury. Scoring systems helps in prediction of the mortality.
So, Dr. Akshat, what is non-oliguric AKI?
When the urine output is less than 0.5 ml per kg per hour, and there is still rise of serum creatinine, it's non-oliguric AKI.
Less than 0.5 ml per kg per hour is non-oliguric.
No, I think you got the terms mixed up.
What is oliguria, Dr. Akshat?
So urine output less than 0.5 ml per kg per hour, sir.
How much? What is oliguria definition?
So oliguria means the urine output less than 50 or 100 ml per day, and anuria is complete absence of urine or above 0 to 10 or 20 ml.
Oliguria is less than 50 to 100 ml. Are you sure?
No, sorry,
Less than
anuria.
500, less than 500 ml would be
Anuria
fine.
is 0 to 50 ml approx.
Yes, so
And
anuria is,
and
Less than 400 ml per day, sir.
okay. So oliguria is less than around 400, 500 ml per day, and anuria is less than 100 ml. Now, what is non-oliguric AKI? So non-oliguric means it's not oliguric. So what does that mean?
Urine output is more than 400 ml.
Okay, more than 500 ml. So does it have a better prognosis or a worse prognosis, Dr. Vishal, than oliguric AKI, non-oliguric?
sir, better prognosis.
Okay.
They have intact GFR.
Okay, so they have a not an intact, they have a better GFR. That is why they
Better
produce
J.
urine, right? Because the urine production depends on how good your GFR is, and the other changes also in terms of physiology are not that much marked in non-oliguric. Fair enough. Now coming to uh, uh, what is the commonest cause of oliguria in the ICU patient? Production?
Sir, hypovolemia, sir.
Okay. Hypovolemia or more specifically hypoperfusion. Hypoperfusion is a better word. Okay, because
Okay, sir.
all patients who are hypoperfusing are not hypovolemic. Okay. What is that called? What kind of acute kidney injury is that called in terms of classification?
Prerenal.
Pre-renal.
Prerenal
Prerenal
AKI.
AKI, sir.
Okay. So is the word pre-renal going out or is it still active? Are we heading towards some change in the definitions?
There is a move actually in the current this thing in which they have formulated a lot of things that are meant to be changed during the course of next year or so, and they've invited recommendations for the same. This is part is one of them.
So we are moving away from certain definitions and pre-renal, etc., maybe going out, and it is going toward more of phenotypes. And problem with pre-renal is, when you think of pre-renal or classify it as pre-renal, one tends to give fluids. But pre-renal also includes diseases like congestive heart failure, right heart failure, or patients with abdominal compartment syndrome. They are also classified currently as pre-renal, but they do not benefit from fluids. They can be actually deteriorating. So the trend is towards reclassifying AKI, and dividing them into different phenotypes rather than what is the conventional classification. Now, I would like to know what kind of next slide, Dr. Akshat.
What is the differentials for an oligouric, anuric
Now,
patient in
just
ICU?
about the case. The patient has rhabdomyolysis and he is in AKI with a worsening creatinine. At what GFR does creatinine start rising? Dr. Akshat, can you hear me?
Sir, pardon, sir?
At what GFR does the creatinine start rising?
Sir, less than 60 ml
Okay.
GFR, creatinine starts rising, sir.
Okay, so less than 50 ml per hour per minute, the GFR starts rising. Now, this patient obviously has rhabdomyolysis leading to acute kidney injury. Is there any specific treatment for rhabdomyolysis induced acute kidney injury? And did you give anything?
We do not have a practice of giving mannitol or anything of that sort for these type of patients. We basically, because mannitol comes with its own share of controversies, we don't give that.
Okay.
Neither is alkalinization of urine a very evidence-based measure. So it's basically whenever we see a case of rhabdomyolysis, we tend to focus on hydration first. That's all.
So, like Dr. Jain sir has said, the other things which are controversial are mannitol administration and giving bicarb to alkalize the urine pH. These are highly controversial and there is no evidence. The evidence is for good hydration and try to maintain a urine output. Now, coming to myoglobin-induced acute kidney injury. So, what kind of renal pathology do you get in these patients? Why do you get acute renal failure in patients of myoglobinuria?
The myoglobin is completely albumin protein bound, so it gets filtered in the kidney immediately. After filtering in the kidney, in the PCT, the myoglobin gets absorbed. There is a ferrous to ferric conversion of the heme pigment, and that causes necrosis and apoptosis, sir. Basically, that initiates inflammatory mediators, sir.
Okay, so it damages the tubules, right? Myoglobin damages the tubules. But what you said about protein binding is not correct. It is not protein bound. If anything is protein bound, it is not freely filtered. A basic understanding. Whatever is protein bound does not get filtered. Okay, easily. So it is free in the serum, it gets filtered. and it damages the tubules. So it is toxin mediated acute tubular necrosis that you get with myoglobin. Okay, good. Carry on.
So any other classification? So
Last slide you have not said.
So any differentials for an oligouric, anuric patients is early monitoring of urine output, assessment of the catheter position and patency, examination of palpable bladder, flushing of catheter, absence of mechanical reasons, and look for other causes.
Next slide.
So any other classification? So nowadays we follow KDIGO classification, that is kidney disease improvement global outcome classification. So the diagnostic criteria in KDIGO classification is AKI is defined as increase in serum creatinine by more than 0.3 mg per deciliter within 48 hours, or increase in the serum creatinine to more than 1.5 times from the baseline, which is known or presumed to have occurred within the prior 7 days, or urine output of less than 0.5 ml per kg per hour for 6 hours. And the staging is as AKI stage 1, that is increase of serum creatinine by 0.3 mg per deciliter, or increase to 1.5 to 1.9 times from the baseline. Urine output less than 0.5 ml per kg per hour for 6 to 12 hours. AKI stage 2 is increase of the serum creatinine to 2 to 2.9 times from the baseline, and fall in urine output of less than 0.5 ml per kg per hour for more than 12 hours. And stage 3 is increase in serum creatinine by value of more than 3 times from the baseline, or urine output less than 0.3 ml per kg per hour for more than 24 hours. Or it can also be categorized as serum creatinine more than 4 mg per deciliter, or the patient is on renal replacement therapy, or if the patient's age is less than 18 years, we can estimate GFR if less than 35 ml per minute per 1.73 meters square, also can be staged as AKI stage 3. And for urine output, if patient is anuric for more than 12 hours, is also labeled as AKI stage 3.
Okay. So this is the most accepted classification now. KDIGO is the one we are normally using. Next. Don't have to know rifle and Akin classification. This is good enough for the students. Next.
So what are the problems we face using serum creatinine as AKI marker? So if there is an administration of the drugs which interfere with tubular secretion of creatinine, for example, cimetidine, trimethoprim, there can be misdiagnosis of AKI, that is rise in serum creatinine without change in renal function. If there is reduced production of creatinine, that is if patient is very lean, thin, cachexic, there is loss of muscle wasting, liver disease, patient is in sepsis, can be delayed or misdiagnosis of AKI. Ingestion of substances which lead to increased generation of creatinine independent of the renal function, that is creatine, cooked meat, and this can lead to misdiagnosis of AKI. Obesity, overdiagnosis of AKI if using actual weight when applying urine output criteria. Conditions associated with physiologically increased GFR, for example, pregnancy, can also cause delayed diagnosis of AKI. Interference with analytical measurements of creatinine, for example, 5-fluorocytosine, cefoxitin, bilirubin, can lead to misdiagnosis and delayed diagnosis of AKI. Fluid resuscitation and overload can cause delayed diagnosis of AKI. Progressive CKD with gradual rise in serum creatinine can also lead to misdiagnosis of AKI. Extrinsic creatinine administration as a buffer in medications, for example, dexamethasone, azacetron, can cause pseudo AKI. Oligouric due to acute temporary release of ADH, that is post-operatively nausea, pain, can enhance by maximal sodium reabsorption in the setting of volume and salt depletion, can also cause misdiagnosis of AKI.
So, Dr. Vishal, what is the normal serum creatinine value in human beings?
Sir, one, sir, less than 1 milligram per deciliter.
Is there a fixed value or is it less than 1?
Sir, 0.3 to
Okay, very good.
0.1.
So there is no fixed value less than 1. Anything more than 1 is 1 milligram per deciliter is abnormal. Now, what are the two main caveats with the use of creatinine in the ICU? A patient has been in the ICU for 1 week, right? And he has suffered some renal insult. But what can be the fallacies in interpretation of creatinine, looking at whatever he has said?
Sir, GFR is more reliable than creatinine level.
Yes, but how do you calculate GFR in the ICU?
So there is a formula actually.
What is it called?
So Cockcroft formula, it is 140 minus H divided by 72 times of the serum creatinine. Whatever the value comes is the value of GFR. We take 85% of that value if the sex is female.
Very good. So Cockcroft God formula is valid in the ICU. That is the easiest way, though it is not 100% accurate. Now, how do you calculate in obese patients? What weight do you take?
So we take ideal body weight if the patient is obese.
Ideal body weight you cannot take. Patient is
Even if
120
we compare,
kg.
yeah, even if we compare, there are two equations, sort of, there's another thing called as MDRD equation. And if you try to test this equation for the same patient, always MDRD values tend to come out lower than the CG equation. So actually speaking, as per evidence, there's no standout formula that can absolutely calculate the GFR extremely accurately, because you need to have something which is going to do it on a real-time basis, which makes it very, very difficult.
Yes. So, in an obese, the other formula, like I said, is MDRD. That can also be used. But Cockcroft formula is the gold standard. And in obese patients, for anything, in obese patients in the ICU, we use the adjusted body weight. So adjusted body weight is the ideal body weight, and to that you add around 50% of the difference between the actual body weight and the ideal body weight, right? So if the patient is supposed to weigh 80 kgs as per his height and is 120, so you take 80 as the ideal body weight and you add 50% of 120 minus 80, that is another 20 kgs. So 100 kgs you take as a weight, because you cannot just remove all the weight that the patient has, excess weight. So that is called the adjusted body weight. For giving drugs, for giving fluids, for calculating nutritional intake, you use the adjusted body weight. Though it is not 100%, but that is the best we can do currently. And the other thing is, what is the best way to, we have talked about the Cockcroft formula. That is easy and that requires only the creatinine. And you look at the weight. Weight, again, you do not know the weight, but you have to estimate the weight, because most of our beds do not weigh the patient. What is the best way actually, Dr. Vishal? If you want to, supposing you want to give a toxic drug and you want to know the GFR, what is the best way? Dr. Akshat or Dr. Vishal, what is the best way of calculating GFR in the ICU? Most accurate. Have you heard of the timed urinary sample? So what you do is you take a 6-hour urine sample. You collect urine over 6 hours and you see the creatinine in that. And you see the creatinine before sending the urine sample. So you calculate the total creatinine, right, in the urine sample and divide it by the serum creatinine. And that, is equal to the GFR. Okay? I hope you understand. The total GFR into serum creatinine is equal to urine volume into urine creatinine. So from that you calculate your GFR. That is the most accurate way to calculate GFR in the ICU. Though it is not practical, but that is the way if you want to calculate the most precise GFR in the ICU. Okay. Now my first question was, what is the problem with creatinine use in a patient who has been in the ICU for a week? So two things happen to the patient in the ICU who's been there for a week. Generally, they are fluid loaded. So excess fluid will dilute the creatinine. So it will be falsely low, their serum creatinine. Dr. Vishal, remove your hand. We can't see your picture otherwise. Yeah. So the creatinine will fall. The other thing is they lose muscle mass. It has been seen at 1 week, patients lose around 25% of the lean body mass. And creatinine comes from where? Where does creatinine come from, Dr. Akshat?
So it comes from muscle only, sir.
Yes. So it comes from muscle metabolism. There's a constant production. So if the muscle mass decreases, creatine production decreases. And if there's excess fluid, serum creatine gets diluted. And you know, even a 0.3 rise of creatinine is equal to acute kidney injury. So you are not able to pick this up. You are underdiagnosing acute kidney injury. So these are some of the fallacies with use of creatinine. Please remember a marginal increase also of 0.3 milligram per deciliter of serum creatinine is equivalent to acute kidney injury. That is the kinetics of serum creatinine. Now, next slide.
So what are the categories of AKI? As we have seen, pre-renal, cause outside before the kidney, renal, that is intrinsic, and post-renal, which is due to urinary tract obstruction. So how to put everything together for...
Which kind of kidney injury does this patient have?
Sir, intrinsic.
So where does that fit in?
Renal.
Renal, sir.
That is renal. Okay, next.
So how to put everything together for diagnosing AKI? So serum creatinine, it is cheap, easily measured, readily available, well-known relationship to the disease. What is the limitation? It is slow to change in response to injury and insensitive, no changes until more than 50% of the loss of the function. Increase of more than 50% over less than or equal to 1 week or more than or equal to 0.3 mg per deciliter over more than 48 hours, used as a consensus criteria for AKI. For urine output, faster to change than creatinine, it is cheap and easily measured. Limitation is it is non-specific, insensitive to certain forms of AKI, not reliably measured outside the ICU. Less than 0.5 ml per kg per hour of more than equal to 6 hours, used as a consensus criteria for AKI. Serum cystatin C is experienced from CKD, similar to creatinine. Urine sediment can help identify specific causes of AKI, for example, glomerulonephritis. Limitation not standardized and usually non-specific. Kidney damage markers measures cellular injury rather than the organ function, not standardized or not completely validated in humans. For example, KIM1, NGAL, and others. AKI risk markers, measures of kidney stress or systemic inflammatory status rather than injury per se. Measures of kidney stress or systemic states rather than the injury per se. For example, NGAL, TIM2, insulin growth factor beta 7. Functional stress test, examine capacity for increases in the function by stressing the system. Tests are not well standardized. Comments are includes protein load and furosemide.
Next slide.
Some more points. If oligouric or anuric continues beyond several weeks, severe acute tubular necrosis or cortical necrosis should be suspected. If hypoperfusion is prolonged, tubular damage results. In most oligouric cases, the cause is pre-renal, that is 55 to 60% in cases. Trial of resuscitation, including volume, should be attempted for pre-renal. Uncorrected hypoperfusion may aggravate renal insult.
So, Dr. Akshat, what happened in these patients? What about the fluid resuscitation and the response to that?
Sir, on day 1, the creatinine was 1.8 and on day 2, it is 2.5. Though we have resuscitated adequately.
How much fluid did you give?
Hemodynamics. Sir, in a period of... yes, sir.
On first day, how much fluids did you give?
So we have given approximately 2 liters, sir.
And was there urine output?
Yes, sir. There has been a marginally improved urine output, sir.
No, what was that? There must have been some urine when you put in the Foley's. That is the initial urine output. After coming to the ICU, how much urine output did he have on the first day?
The day 1, he had around 700 ml. Day 2, he just went on to have progressive decline in urine output. And that was the time when we decided that this thing is not working. He was given actually a fluid resuscitation, a bolus of 500, followed by at around 120 to 150 mils per hour on day one. But didn't respond to the same. Second day, we continued till that point in time. But the problem was that he started having some basal lung signs. So that's when we decided that now is the time that probably we should stop pursuing the policy of aggressive fluid resuscitation for him and
So,
think about considering dialysis.
so what kind of basal signs did he get in the lung? I mean, did you see the B lines or there were crepitations or what?
There were increased B lines and there were crepitations.
Okay. So after how much time of fluid resuscitation did you develop B lines?
This was around 4.5 liters.
So on first day you are given 4.5 liters.
First day around 3 liters. By second day, another 1.5 liters had gone in.
So did you look at any parameter for fluid responsiveness or you targeted only the B lines, you kept giving fluids?
We looked at B lines. We do sometimes we do the VTI test wherein before we give the fluid, we look at the VTIs and then subsequently after that we again sort of do the VTIs after giving a volume bolus. But this particular patient, because rhabdomyolysis was well established anyway, he had a total CPK of around 15,000. So we continued with fluid in the hope that this should turn around at some point in time.
Okay. So Dr. Akshat, what kind of fluid responsiveness test can you do in these patients? We could have been more, you have given 3 liters on day one. Maybe you could have been more aggressive. Any test you would have liked to do for assessing fluid responsiveness and maybe give fluids more aggressively? Dr. Akshat?
No idea, sir.
So we can see the IVC. We can do a passive lag test. We can see a velocity time integral test.
So IVC, what would you like to see in IVC?
So whether it is a collapsing or it is a plethoric.
So how do you see that?
By 2D echo probe we can see.
No. What do you see in that?
Sir, collapsible or it is a distensible or it is a plethoric. By see the diameter.
So are there cutoffs for this?
Sir, more than 2.65 centimeter is dilated.
So are intermediate values of help or only extreme values are of help?
Sir, extreme values are helpful actually.
That is very important. Less than 50%, more than 50% is not reliable. Only extremely dilated or extremely collapsed IVC is help. Right? That is one. Then passive
There is
leg
another
raise.
caveat to it that the patient, if he is spontaneously breathing, then at times there can be certain other variables coming in which may be confound us when we interpret the IVC diameters.
Okay. So now coming to passive leg raise. So do you have these beds, automated beds, Dr. Vishal?
Sir, we have an automated bed.
So how do you do passive leg raise?
Sir, first we sit a patient, make a patient in the 45-degree recumbent position.
So in this patient, how could you have done? And we should be using more of passive leg raise, but we are not using. If you have automated bed, you should use it. How do you do it? Tell the audience.
We make the
Sir,
patient supine, sir. We make the patient supine.
Let Dr. Vishal tell. Dr. Vishal, you tell.
Sir, if we make the patient supine, we recommend the position to 45-degree. Then we put a patient back to the supine and increase the lag to almost 45-degree. The increase of more than 10% stroke volume increase the fluid responsiveness.
No. So you have to first tell the patient that you're doing something, right? You have to make sure the patient is not anxious. All right. Then you have to have a device to measure the cardiac output in place. Huh? So that device, what do you have a device to measure the cardiac output?
Flow track we have, sir.
Okay, so you put the flow track on, has to be there. You have to see the cardiac output, the baseline. The head end has to be elevated to 45 degrees, and okay, and then you lower the head end, and then you elevate the foot end to 60
Lag.
degrees. and at 1 minute you see any increase in cardiac output. That is how you have to do it. And if you don't have automated bed, this process has to be done by the manual method.
Manual.
And you should, when you do it manually or any time, there should be no tachycardia. Because if you get tachycardia, that means you are stimulating the sympathetic system. And if you stimulate the sympathetic system, the hemodynamics change. That is very important. Okay. So, and do not cause pain at any time, because that also stimulates sympathetic system. So when you do automated bed, the cardiac output should increase by at least 10 minutes after 1 minute. If you do not have cardiac output monitored, you can look at MAP. MAP should increase by around 15 to 25% at 1 minute. And it's a very simple test. But the point here is, when was the injury? On the leg, the rhabdomyolysis?
No, sir. There was no specific signs of injury, anything found of that sort. He was extremely tender, but there were no obvious bony injuries.
No, but he was tender all over or on the extremities?
He was tender all over.
Okay, so there was no focus. So you could have, well, one can do the passive leg raising in him. If you get tachycardia because of pain, then it gets negated. So the only thing is, because in these patients, in the beginning, if you give a lot of fluid, it may help if they require fluids. Because if you delay it, then the injury becomes irreversible. It would have been irreversible, but in acute kidney injury, aggressive fluid depletion helps in the ultimate prognosis. So that is the only thing that is important here. Okay, so carry on.
Another thing that we can do in these patients is probably not done for this particular patient, because hemodynamics, was sort of not that bad. So for him, like if you have an arterial line, sometimes you can put in an arterial line and look for pulse pressure variation as well if you do not have a cardiac output monitor. That's relatively crude. Even that comes with a lot of variables. And there's a small study which talks about even changes in EtCO2. But this is just for, for the discussion's sake. Nothing more.
But pulse pressure variation, how would you like to use in a patient who's not on the ventilator?
That's what, sir. I mean, I was just putting it as a general.
You're right. No, you are right. I'm just asking you to elaborate. So the thing is,
we would be looking at 10% increase in pulse pressure.
Yeah, you can look at 10% increase after giving fluids, or you can take 20% as a cutoff for fluid responsiveness. The cutoff goes up. So if you're getting a lot of variation in your pulse pressure variation in a spontaneously breathing patient, that also indicates fluid responsiveness.
Correct.
You see, why pulse pressure variation requires controlled ventilation? Because spontaneously breathing patients have different tidal volumes and generate different amounts of intrathoracic pressures. So the pulse pressure variation cannot be standardized. That is the thing. But if there's a lot of pulse pressure variation to the tune of 20%, then it's obviously fluid responsive. That is the thing. And the other thing that you have said is you give the fluids and see. But there, you'll be giving excess fluids. So sometimes you don't want to give fluids. That is the only thing. That is the downside of giving fluids and seeing the response of the pulse pressure variation. Okay, carry on, Dr. Akshat.
So what are the caveats on fluid resuscitation? Aggressive fluid resuscitation is associated with increased mortality over a diverse group of patient subsets. The rationale is to give just the right amount of fluid rather than keeping the patient wet or dry. Need to embrace newer parameters of the fluid resuscitation and need to switch over to passive leg raising, IVC distensibility, and VTI measurements.
So, Dr. Akshat, that excess fluids lead to worsening of renal function? Can excessive fluid loading lead to worsening of renal function?
Can excess fluid? Yes, sir, can lead to.
How?
So if it is renal type of AKI, or if it is post-renal type of AKI, giving excessive fluid will hamper renal parenchyma and will cause increase in the creatinine level.
How renal parenchyma gets affected by increased fluids?
So suppose if a patient has a renal calculi or post-renal AKI, giving more fluids will.
The answer is in the image before you, actually.
Yeah, the salt and water retention, the increased GFR.
So, Dr. Vishal, you want to tell how excessive patient who has a lot of fluids, how will renal function worsen? Why?
Sir, there will be a salt and water retention by the excess fluid.
Salt and
There
water.
will be a
No.
third spacing leak
Worsening of renal function.
intravas.
Supposing you have a patient of AKI with a creatinine of 1.8, okay, and you give a lot of fluids, you keep giving fluids, CVP becomes high, cardiac chambers become dilated, he has tissue edema. So what will happen to the creatinine? Will it worsen or will it remain same or will it improve?
Sir, worsen.
Why it worsens the creatinine?
Because of reduced GFR, because of overloaded.
Why the GFR reduces? The GFR reduces because of a couple of reasons, and this is actually very true for cardiorenal syndrome and patients whose right heart failure is overloaded. So the CVP is high, so the renal venous pressure is high, right? Because the return is problematic as it's already congested. So once the venous pressure becomes high, the renal venous pressure, because of high CVP or a lot of volume overload, then the tubular pressure increases, the renal tubular pressure in the renal tubules, okay, because the renal venous pressure is high. And once the tubular pressure becomes high, the filtration from the glomeruli decreases, thereby the GFR decreases. And also there is edema in the kidneys as well, interstitial edema, that compresses the renal tubules and the nephrons. So that is why the GFR actually worsens. You keep loading a patient with AKI, excessive fluids. And even if the patient is not a renal injury, the creatinine go up marginally. That is the problem with overloading, and that is what happens to the kidney. Okay. Apart from, of course, all the other systems. Next slide.
So what is the choice of fluids? 0.9% NaCl is unphysiological. NS is preferred choice for physicians, whereas RS is preferred by the surgeons for reasons unknown. RL can be infused in same venous line as blood. Chloride liberal fluid is associated with higher chances of renal failure compared to chloride conservative fluid. Hyperchloremic acidosis remains a risk. Hyperkalemia related death even in patients of renal failure receiving RL remains unreported till death.
So why does chloride liberal fluid or hyperchloremic acidosis lead to renal failure or a rise in acute creatinine? Dr. Vishal? What is the mechanism of hyperchloremia leading to acute kidney injury? So hyperchloremia, what happens is when the chloride levels increase, it leads to depolarization of the afferent arteriole in the glomeruli, leading to afferent arteriole vasoconstriction, leading to reduced GFR and rise in creatinine. That is the mechanism. And that is the sole reason why chloride rich fluid is avoided now. Okay, and meta-analysis has been done. There's a distinct tilt towards increased AKI with chloride rich fluids. It is not a matter of conjecture anymore. You should avoid it. Some amounts of normal saline is all right, but large amount of fluids has to be given. Then one has to look at chloride levels. If the chloride levels are all right, it's okay, but the chloride level should not increase. Next slide.
So workup, hemodynamics remains decent, no central line. Echo is not contributory. Blood urea nitrogen and creatine ratio was 6.2. Fractional excretion of sodium was 0.8 and urine sodium was 15.
So what is a normal urine BU and creatinine ratio? Dr. Akshat, what is normal BU and creatinine ratio? You have written there, right? In the slide, you have written more than 20 is pre-renal.
Yes, sir.
Huh?
This is written in the slide. More than 20 is pre-renal and less than 10 to 15 is renal.
Yes, sir.
So there is no fixed value in normal. You use the ratio to decide whether the patient is pre-renal or renal. And if it is more than 20, it is pre-renal. It helps you in giving fluids. So what is the relationship between blood urea nitrogen and blood urea? Because blood urea nitrogen is not done in most places. What is done is blood urea. So what is the relationship between blood urea nitrogen and blood urea? So, Dr. Vishal? So blood urea is twice blood urea nitrogen. Huh? Okay, so this becomes 40. If the blood urea to creatinine ratio is more than 40, then 85% of the times you'll be right in giving fluids, especially the younger patients. You can take that unless he has received diuretics or something else. Okay, there can be false elevations of blood urea at times. So what causes a disproportionate rise in blood urea? Dr. Vishal, what
Sir,
can
what, sir?
what can lead to false elevations in blood urea or disproportionate rise of blood urea as compared to creatinine? Where does urea come from and where is it made?
Night.
It is made
If the
from
patient
amino
is-
acid metabolism, sir, urea cycle.
If the patient is highly dehydrated, then probably that should be considered.
Dr. Akshat, where is you were saying something? Where is urea made and where it comes from?
It comes from liver due to protein metabolism, amino acid metabolism, sir.
Okay, very good. So it comes from amino acid metabolism. Where is it made? Where does the urea cycle take place?
Same liver.
Liver. Okay, good. So urea is made in the liver from amino acid metabolism and carbon dioxide also. Carbon dioxide, carbon monoxide goes into urea. And the other thing is that is a clue to what I'm saying. So what can lead to false elevations or disproportionate rise of urea to creatinine? Apart from dehydration, what else can cause a BUN ratio of more than 40? So increased protein degradation, right? Increased
sir.
amino acid degradation, which can occur in stress, in sepsis, in catabolic states because of steroids. Huh? So that will lead to a false high elevation of urea as compared to creatinine. One more important condition is GI bleed, basically upper GI bleed. That also leads to a disproportionate rise of urea to creatinine. Like you may have a creatinine of just 1 and a urea of something like 80, 90. So these are some of the causes where the urea is disproportionately elevated as compared to creatinine. And if the patient comes to you, especially a young patient who has not received diuretics, not received fluids, fresh to the ICU, if you see a urea to creatinine ratio of more than 40, then he will respond to fluids in all probability. He requires fluids. Okay, the other things are not so much important anymore, like FeNA, etc. Urine sodium is the other thing you can use, and a urine sodium of less than 10 again indicates pre-renal causes. Urine sodium of less than 10 again indicates pre-renal. Okay, next slide.
Do pressure heads impact renal dysfunction? So hypoperfusion, that is low renal perfusion, maybe because of hypovolemia or cardiogenic shock or peripheral vasodilation or renovascular. In cardiogenic shock, we have myocardial dysfunction, valvular dysfunction, cardiac tamponade, or peripheral vasodilation, maybe because of sepsis, cirrhosis, or anaphylaxis, and some renal vasoconstriction drugs. So what are the differentials for low urinary sodium? What is the difference between azotemia and uremia? Any correlation of muscle mass with creatinine values? What about the current potassium and phosphate levels? And what about patients who are already on diuretics?
Next.
So what are the keywords? Elevated blood urea levels are referred to as azotemia. Uremia features like pericarditis, encephalopathy, and bleeding manifestation, which may require dialysis. Elevated serum osmolality, serum sodium, and hemoglobin levels indicate hypovolemia. Serum creatinine may be low with small muscle mass and urea may be low with slow protein turnover. For example, malnutrition patients or patients with liver failure. Hyperkalemia and hypophosphatemia indicate a worsening kidney function. In patients on diuretics, fractional excretion of urea is more reliable.
Next.
So what are the points to remember?
You skip this next slide.
So do creatinine values predict mortality? Even a small change that is less than more than 0.3 mg per deciliter per day or a percentage increase in serum creatinine more than 50% is an independent predictor of mortality. So any value of urinary sediment, values of cast in the urine does not retain a significant value in ICU patient. Significant variability in microscopy and urine biochemistry indices and can be used for diagnosis ATN and predicting course.
Actually, the urine sediment has to be interpreted. You have to have a good knowledge of nephrology. Otherwise, because RBCs, WBCs, RBC cast, granular cast, they all have significance. Okay, and they can help. It is not that they are totally unreliable, but you have to have a sound knowledge of nephrology, right? For example, if there is acute glomerulonephritis, the Goods-Patches syndrome, SLE nephritis, then you get a lot of RBCs, RBC casts. If you don't know what is what, then you obviously can't interpret it. But all these conditions are very important, right? So if you know acute interstitial nephritis, you will get a lot of WBCs, WBC cast. Similarly, in acute pyelonephritis, so you have to know what kind of urine findings you get in what kind of kidney disease. Okay, it's not totally unreliable. Biochemistry, of course, can have a lot of variability, but cells and casts have to be interpreted. You have to have knowledge. Next.
Do serum creatinine values add value to AKI workup? So serum creatinine has low sensitivity for renal dysfunction. Rising trends lag behind the tubular injury significantly. With newer scores, lowering creatinine rise thresholds, sensitivity has improved, influenced by changes in muscle mass, sex, race, drugs, body weight, and drugs and protein intake. Novel biomarkers such as IL-8, IL-18, IL-6, KIM-1, and GAL remains investigations are.
So one important point in this slide is that the rise in creatinine occurs after the tubular injury, after the renal injury has occurred. So there's a lag period. If today there's an insult to the kidney, the creatinine will go up after 24 to 48 hours. All right, and it will not stabilize. Okay, the stabilization because the kidney function will keep worsening. So slowly over days the creatinine will rise. If there's an insult today and it stabilizes, right? There's no further insult to the kidney, then the actual creatinine value stabilizes after around 5 to 7 days. It takes that much time. And the rise will occur only after 24 to 48 hours. So there's a problem with creatinine as a marker, but it's the best that we have. And then there are newer novel biomarkers. We will talk about them as we move on. Next.
So significance of history of sepsis or prolonged hypotension, drugs and nephrotoxin exposures, intrinsic renal failure in ATN with differentials of glomerulonephritis, full clinical history with clinical examination, that is misplaced catheter or palpable bladder, and suprapubic tenderness identify post-renal subsets. Confounding variables are confounding injuries, stupor, intoxication, and effects of sedative and anesthetic agents.
So Akshat, if the patient stops passing urine in the ICU, what would you like to do? Suddenly you see the urine output is not there for the last 4 hours. What would you like to see?
Sir, I will rule out any mechanical obstruction. I'll see the catheter is in place or not.
Okay, so it's very important to check for Foley's. Sometimes the Foley gets skinned, sometimes gets blocked, so you have to flush the Foley's. So that is a very important thing. It happens frequently. So the mechanical cause should be ruled out whenever there's acute unexplained drop in the urine output in the ICU. Next slide.
What are the differentials for post-renal kidney dysfunction in the ICU? Altered sensorium, bladder outlet obstruction, prostatism, bladder discomfort, pelvic injury, plus minus urethral injury.
So this is post-renal AKI. These are the causes of post-renal AKI. Okay. Next.
Any specific use of NGAL biomarker in ICU? It is used for early diagnosis of AKI in cardiopulmonary bypass, contrast-induced nephropathy, sepsis, and post-renal transplantation. Early measurement can predict need for renal replacement therapy, mortality, and therapeutic response.
So you see, NGAL is being used in cardiac surgery in some centers, and all these novel biomarkers. They are not only biomarkers; they are novel biomarkers. They are coming more and more into picture. They help in telling about renal injury, acute kidney injury when the urea creatinine has not gone up. They precede the rise in urea creatinine, and they can make you aware that the patient is predisposed to acute kidney injury, and you can take preventive measures. There is no definitive treatment for acute kidney injury, but the biomarkers there are more biomarkers than NGAL. NGAL is only one. So the biomarkers rise before creatinine, and they help in predicting that the patient is going into acute kidney injury, so you can take all your precautions. Apart from that, biomarker help in telling about the severity, what kind of severity the patient may land up in terms of AKI. They help in prognosticating also, and they help in telling what may be the etiology. For example, KIM biomarker, KIM, if that is elevated, that tells that the nephrotoxicity has occurred because of drugs. The AKI is because of drugs. So though these biomarkers have different roles, and they are going to be there in the future, and once they are raised, they help in telling us more about the injury, the prognosticating about the injury, and that we should be instituting nephro care bundles in place. That is the role of biomarkers, but they are very expensive, and it will be a while before they actually come into full use. Next slide.
So any other biomarker then can be used. So marker of glomerular function is cystatin C, hepcidin,
Next slide.
cathepsin.
There are many biomarkers. We already discussed that. Next slide.
So what is subclinical AKI? In 2020, the Acute Dialysis Quality Initiative group proposed a new stage of AKI referred to as stage 1S, which represents subclinical disease defined as a positive biomarker but no increase in serum creatinine level.
Next.
So what is renal angina index? So changes of serum creatinine we take for 24 hours. Elevated creatinine of less than 0.1 mg per deciliter, score is 1. More than or equal to 0.1 mg per deciliter, score is 2. More than 0.3, the score is 4, and more than 4 is 0.4 is the score is 8. For patient condition, we take if patient is having ICU admission, score is 1. If the patient is having DM, the score is 3. If the patient is on vasopressor and ventilator, the score is 5. We take the multiplication product of these two parameters, that is renal angina index.
Next.
So any other test as a part of the workup in AKI? So as other part, we can do USG KUB, plain radiology, X-ray, CT scan, intravenous urogram along with the retrograde and anterograde contrast studies, bladder pressure measurements.
Next.
So any specifics on USG? USG is the first line imaging modality. Kidney size is typically measured in the long axis, bipolar length. Echogenicity is evaluated by comparison with the adjacent tissue like liver or spleen. Hyperechogenicity favors diffuse parenchymal kidney disease.
So what is the normal size of the kidney on ultrasound? Dr. Vishal?
10 to 13 centimeter.
Okay, it's slightly more than that. Is 8.5 to 13. So why is there a variation? Why is there a variation in size? So it depends on the height. It depends on the height, the weight, the body, specific features. It's variable. So what is the significance of kidney size? What is the significance of kidney size?
So it get decrease in chronic kidney disease.
Very good. So it helps. It is the only diagnostic feature which tells you whether the patient has CKD or AKI on ultrasound. Nothing else is differentiating. So if the size is less than 8.5, it tells you that the patient has CKD, right? Okay, and 8.5, it may be more than 8.5 in patients whose baseline kidney is more in size. but you do not know what is the baseline kidney disease, length, right? So 8.5 is taken the cutoff. Even some patients may have a larger kidney size also with CKD. So that is the distinguishing feature between CKD and AKI, because sometimes patients with CKD may land up with acute symptoms, and you do not know whether the patient has AKI or CKD or AKI on CKD. So it becomes very important. That is the significance. And diabetic nephropathy patients have enlarged kidneys, because a lot of patients have diabetic nephropathy. So their kidney size remains normal or increased even with CKD. Next.
Another variable to that extent would be a polycystic kidney disease. If the patient is having that, then also the size may be larger.
Yes, definitely. So enlarged kidneys, maybe in diabetic nephropathy, polycystic, HIV nephropathy, renal cell carcinoma, myelinosis. So there are some causes, like you said. The commonest is polycystic kidney disease, but some very few causes of enlarged kidneys are also there. Absolutely. Next.
So what about Doppler-based resistive indices? So intrarenal resistive index calculation based on the peak systolic shift and minimum diastolic shift. RI is considered as normal if less than 0.7. Normal range is age dependent. Changes in RI to help in titrate norepinephrine in MAP in ICU patients influenced by cardiac output, heart rate, PaCO2, PaO2, intraarterial pressures, and renal interstitial pressures. Needs further studies. Contrast enhanced USG to document cortical necrosis.
Next.
So moving on to case, as his oliguria progressed and worsened, further the nephrologist was consulted and the patient was promptly put on a diuretic infusion. Is it appropriate? So giving diuretics in AKI. So have a role in management of hyperkalemia and volume overload. No clinical benefits. No effect on outcome of renal injury. Paradoxically, may even increase mortality risk, lead to poorer recovery of renal functions, especially in oligouric patients with diuretic resistance.
So the diuretics are harmful if you give it in a hypovolemic patient, right? Otherwise, in a patient who is volume overloaded and you produce urine, they are helpful only. Okay. Next.
So
Yes.
what is furosemide stress test? So appropriate candidate for furosemide stress test felt to be adequately resuscitate. Persistent oliguria, doubtful that a fluid vasopressor inotrope challenge would help or not. So we have given furosemide stress test. If the patient is diuretic naive, we give 1 mg per kg of IV bolus. If not, then a slightly higher dose, that is 1.5 mg per kg of IV bolus is given. And we monitor the urine output for 2 hours. If it is more than 200 ml, we call it as a positive furosemide test test. It is useful in prerenal. It is used in diagnosis of prerenal oliguria. Replace urine output. Attempt further hemodynamic manipulation to improve the urine output. Urine output may be a useful measurement of organ perfusion. If the urine output is less than 200 ml in 2 hours, we call it as a failed furosemide stress test. That is intrinsic renal failure. Additional fluid, vasopressor, or inotropes are unlikely to improve urine output. Urine output isn't a meaningful measurement of perfusion.
So what does so if the patient produces urine more than 200 ml, what does that mean in FST? If the patient produces urine, then what does that mean? What is that? What is the significance of that?
The patient will more likely be fluid responsive.
Yeah, but in terms of renal function, what does that mean? Fluid responsiveness is not the issue here, because he's already volume resuscitated. So what does FST urine production mean? That the tubules are working. It means that the tubules are working and the patient is not likely to progress further immediately into worsening renal function. And then you can hold dialysis. That is the implication of a positive FST. That if the patient produces urine 200 ml in the next 2 hours of your Lasix, it means that the renal tubules are working and he does not require immediate dialysis. And you can continue with conservative management and put him on Lasix infusion or intermittent Lasix doses. So that is the implication of furosemide test. Also, it has been seen whether you use FST or not to guide RRT, the outcome is the same. Though FST is a very good test for deciding about RRT, its use has not changed the outcome in terms of mortality or eventual long-term outcomes in patients with AKI. Next. Next slide.
So,
Next. Okay.
so as he remained unuric despite hemodynamic optimization, a decision was taken to subject him to ISD. So could I have timed my ISD earlier? So what are the timings of RRT?
So what is the timing of RRT? You tell. Akshat, when do you do RRT? Should you do early or late? Dr. Vishal?
Sir, we should wait, sir, for at least 24 hours to 48 hours. We should wait.
24 to 48 hours of what?
To see the output of the patient, if he is pouring the urine output.
No, patient is in acute kidney injury. When would you like to do the dialysis? What is early and what is late?
The rising creatinine level with overload patient.
So early or late would be actually defined as per the duration here. One, and as per the stage of the kidney injury.
So early and late is actually, this is something which people don't realize. Late means classic indications. Hyperkalemia, volume overload, pericarditis, uremic encephalopathy. And early means when there is none of this indication. You decide arbitrarily, the patient is not looking good, and you feel clinically that the patient should go for dialysis. And trials have shown there is no decision on this. Either this way makes no difference. So ultimately, it's a clinical judgment. It's a clinical judgment. And generally, the clinical judgment is that the patient is getting volume overloaded because you don't want the patient to get volume overloaded. It is harmful. Or some other things are happening, like potassium is becoming unmanageable, acidosis is becoming very severe. So these are the indications where you decide RRT. And multiple trials have shown neither early or late is the answer. It is a clinical judgment. And normally in practice, a urea of around 150 to 200 or a creatinine of around 4 is an indication for dialysis. All right. So that is the way this dialysis is being done now. And that is what the clinical evidence is. Next.
Should I remember anything about dialysis catheter insertion? It has to be USG guided, both femoral and jugular, acceptable. Avoid subclavian. Catheter tip colonization more in femoral with higher BMI and not on chlorhexidine impregnated dressings. Heparin based locking is standard, but greater chances of hit and bleeding complication is susceptible patients. In catheters less than 25 centimeter length, for lower flow capacity catheter dysfunction and recirculation was higher with femoral location. Placement in left IJV predisposes to greater catheter dysfunction. Patient with femoral catheters also can be safely mobilized for physio.
Next.
So, are there any BP targets? What fluid should we use and what to be avoided, and what pressures to be used?
So what is
Final
the
course.
what is the vasopressor of choice for AKI? Hypotension and AKI?
So, norepinephrine.
Okay. Is there any advantage of vasopressin?
In septic patients, sir.
What advantage has been seen in vasopressin?
It improved diastolic function.
Diastolic function. So vasopressin has been shown to have a renoprotective effect, but the evidence is in the guidelines say that norepinephrine is the first line vasopressor. Okay, but vasopressin has a renoprotective effect. It has been seen in trials. Okay, so that is about vasopressin.
Another thing that happens is that most of these patients tend to be in acidosis whenever we talk in terms of AKI subsets requiring dialysis. So in acidotic milieus, the quantum of catecholamines that would be required, the requirement becomes much more higher, because with acidosis they tend to work inefficiently. So using a different mechanism of raising your BP in terms of using a different receptor or using a different drug that goes through a different receptor would be a good idea.
Yeah. So definitely that is a good point, because catecholamines effectiveness goes down with acidosis. So that is a valid point. The way actually vasopressin also helps is it causes efferent arterial constriction. So it increases the GFR. Okay, so it has been seen that the need for RRT is less with the use of vasopressin. However, the guidelines say that norepinephrine is the first line if you have hypotension with AKI. All right, but consideration can be given to early use of vasopressin in these patients if there is a dual need, rather than waiting for higher doses of noradrenaline. Okay. Now coming to MAP targets. So Dr. Akshat, are MAP targets 60 to 65 in all patients, or you like to consider higher targets in certain patients?
So if the patient is a known hypertensive, we'll target higher MAPs.
Okay, very good. Next slide. Just one more here. Just go back. So you have mentioned plasma expanders such as starch and dextran should be avoided. So what is the problem with these?
So they are nephrotoxic.
What is the mechanism for nephrotoxicity?
I'm not sure, sir. I think it's a free radical generation in tubules. Not sure, sir.
They stay in the circulation for more than 24 hours. Large molecules. They causes a tubal obstruction.
Tubular obstruction. What is the mechanism of renal injury with starches and high colloids of such a nature? So they go into the interstitium, right? They get filtered and they go into the interstitium where they are nephrotoxic. So they cause injury in the interstitium, and thereby the tubules get injured. That is the mechanism of action. Okay, next.
Going further into the case, the patient was subjected to ISD, and as his parameters improved, he showed a decline in the total CPK levels along with the improvement in electrolytes. However, urine output remained poor and he kept on requiring dialysis intermittently. He remains on follow-up after discharge and is dependent on IHD.
Next.
So what is AKD? Acute kidney disease has been proposed to define the course of disease after AKI among the patients in whom the renal pathophysiologic processes are still ongoing. AKD period represents the time window wherein the critical intervention might be initiated to alter the natural history of kidney disease, that is from day 7 to day 90.
So stop the share screen. Okay. So that was about this patient who had, rhabdomyolysis due to electrocution and myoglobin release and myoglobinuria AKI. And because he has come to you a little late, I think, and because myoglobin and pigment induced renal injury has a bad prognosis, he has gone on dialysis, right? He requires maintenance dialysis. Now, the other thing is, what else can we do now? This is for everybody. If you get a patient with myoglobin induced renal injury, is there anything else we can do in terms of treatment? Because bicarbonate and mannitol have not withstood the test of time and evidence does not really support. You can try it, there's no harm. But what else is new which can be done? If the patient comes to your ICU with rhabdomyolysis and acute kidney injury, anything you can do? Something which has been, recent advances. Anyone, Dr. Akshat, Dr. Vishal, younger patients, younger lads who read the latest? So you can put a cytosol filter. You can put a cytosol filter. So some studies, there has been one recent study, they used a cytosol filter and they have seen that myoglobin levels decrease and it may be helpful, right? So you can use a cytosol filter and you can follow myoglobin levels. Actually, people are also doing serum myoglobin levels because it is myoglobin which causes the injury, not CPK. CPK is an indirect test. So if you're doing myoglobin levels, you can do myoglobin levels And even if you are not doing myoglobin levels, as far as treatment is concerned, one can actually use a cytosol filter in these patients and be aggressive with your fluid resuscitation, because fluids are good for the kidney till the point where the kidney either recovers or stops functioning. But initially, it's better to over resuscitate the kidney rather than under resuscitate. Fluids are good for the kidney and bad for the heart. Just remember that. Okay. So with that, I think we come to the end of the session. Any questions from the audience? We'll take. Dr. Akshat, any questions?
No, sir.
Okay. Dr. Vishal, any questions?
No, sir.
Okay. Dr. Niklesh, you want to comment? Make any comments?
Well, maybe, if this patient were to have an imaging or something of that sort, or a vascular injury, maybe a separate section on contrast-induced nephropathy may have been included, but that's a whole new topic in itself, one. And probably the other thing that may need to be added to this is sometimes these patients can be subjected to CRRT. But again, all those are independent topics in themselves and would require at least one full session rather than accommodating everything in one.
Yeah. Okay. So thanks, Dr. Niklesh. And thank you, Dr. Akshat, for the presentation. Thanks, Dr. Vishal, for joining in. And
Thank you,
I
sir.
thank the audience for
Thank
their
you so much,
patience.
sir.
Thank
Thank
you.
you, everybody. Thanks.
Thank you, sir. Thank you.
Thank you.
Thank you, sir. Thank you, sir.
Thank you.